Good afternoon, I'm Dr. Patrick O'Gara, and I'm here at the American Heart Association Scientific Sessions 2014 with Dr. Mark Dayer and Dr. Martin Thornhill to my left, who are the principal investigators regarding a trial of infective endocarditis prophylaxis in the United Kingdom. Good afternoon, thanks for joining.
Good afternoon.
Mark, let me ask you, where are you from?
I'm from Taunton, which is in the southwest of England.
Fantastic. Martin?
I'm Professor of Oral Medicine at the University of Sheffield.
Terrific. Well, thanks for interacting with us general cardiologists. You've authored a very important study, and Mark, I wondered if you could give us a snapshot of the infective endocarditis study that you're going to be presenting tomorrow.
Okay, so in 2008, National Institute for Clinical Excellence introduced new guidance in the UK which recommended that antibiotic prophylaxis should no longer be used at all. And what we have done is we've looked at antibiotic prophylaxis prescribing, and we've looked at the incidence of infective endocarditis. And what we've shown is there's been a dramatic fall in the number of antibiotic prophylaxis prescriptions issued, about 90%. And there's been a rise in the number of infective endocarditis cases above a baseline trend, which was going up anyway.
Is that right?
Yeah.
So, Martin, is this a cause and effect relationship? Is this an observation? How should we make sense of this?
No, we definitely can't say there's a cause and effect here. What we've seen are two things happening in parallel: a fall in prescribing of antibiotic prophylaxis and an increase in the incidence of endocarditis. But just because there's an association, we can't draw the conclusion that the fall in antibiotic prophylaxis actually caused the increase in endocarditis.
Yeah. Mark, do you think that this is going to change your practice?
I don't think it's going to change my practice yet. What's really important, I think, is that the data is sent to the committees and they review the data, because we're a little close to the data. So we think it's important that it's independently evaluated before we change practice.
So a little consideration and a little bit of time and making sure that we don't overreact.
Absolutely.
But go ahead, Martin, I'm sorry.
I was just going to say that the NICE, which is the National Institute for Care and Health Excellence in the UK, that set these guidelines, has just released a press release to say that they are going to immediately review the guidance, the current guidance. And their recommendation in the meantime, while that's happening, is that practitioners should continue with the existing guidance in the UK while the review's happening.
Now, did your study allow you to identify people who might be at higher risk versus those at lesser risk of endocarditis? Because I think our guidelines in the US differ a little bit from the NICE guidelines with respect to populations of patients for whom prophylaxis is recommended.
Well, NICE no longer recommend antibiotic prophylaxis to anyone at all, high risk, moderate risk, or low risk. So it's a huge change in practice. What we have tried to do with the data we have is identify what has happened to patients at the highest risk of infective endocarditis and the remainder of the patients.
And what did you find? Is there a difference?
We found a rise in both groups. The magnitude of the rise seems to be slightly bigger in the lower risk group, and that would include moderate and low risk patients.
Now, Martin, are most of these patients ones who would receive prophylaxis for dental procedures, or are some patients, you think, still receiving prophylaxis for non-dental procedures?
Well, the guidance as it stands at the moment in the UK is that none of these patients should receive antibiotic prophylaxis. However, we do know that there is still some residual prescribing of antibiotic prophylaxis going on, and other studies that we've done, not this one, have indicated that's principally being targeted at patients who you would categorise as being at highest risk.
Do you have any sense of the microbiology here in terms of the people most likely to develop endocarditis? Are these streptococcal infections that we're seeing?
Well, we had hoped to look at that. We have attempted to look at the issue of what organisms are causing the endocarditis in the group where the increase has occurred. Unfortunately, because of the way the data is collected in the UK, every single patient who's admitted to a hospital in the UK has to have a diagnosis attached to them but there's no requirement for the causal organism
I
to be
see.
recorded.
I see.
And so we only got that data in a small proportion of cases, not sufficient to draw any conclusions.
Fantastic. Mark?
The other problem is that there are no ICD-10 codes specifically for Viridans streptococci,
I see.
and that's a real limitation, unfortunately.
Do you think we'll get a randomized trial put together in the future? Last comment.
Well, unfortunately, if we want to improve the level of evidence we have, then really we need a randomised controlled trial. I don't think it will be easy, but that obviously would be desirable.
Do you think the UK National Health System provides a platform for that? What do you think, Mark?
I think it does provide a platform for that. The data collection there is getting better and better.
Terrific.
And I hope we can put one together. Whether the UK is big enough to do a trial is another question.
Fantastic. Well, thanks very much for spending this time with us, and we look forward to your presentation.
Thank you very much.
Thank you very much.